Okay, sir. Okay.
Okay. Very good evening to all, respected teachers, seniors, and colleagues. So we have another session of oh. We have another session of okay,
Ready,
okay. We have another session of IAP Tirunelveli Journal Club today, and we have Dr. Soumya, S, Senior Consultant Endocrinologist, Cosmo Hospital, and the presenter is Dr. Jisna Najeem, analysis by Dr. Fathima A. Rahim Koyekutti. And we have Dr. Ramakutty sir here and Dr. Padmanabhan sir. Before we start the session, I request Dr. Srijit to tell a few comments. Over to Dr. Srijit.
Okay, thank you, Anju. I once again thank the Journal Club team to organize Journal Club in a monthly fashion. So I congratulate the Dr. Anju and for coordinating this well. And also very grateful and thankful our senior faculty, Dr. Ramakutty sir and Padmanabhan sir for chairing these sessions, and looking for the wonderful presentation from the Cosmo team led by Dr. Soumya and his PGs. So we are waiting for the academics to happen, and wish you all the best, and waiting for the club to start. Thank you.
Thank you, Dr. Srijit. That we have Dr. Benno also, faculty from Cosmo, and previous secretary IAP Tirunelveli, and others also will be joining. So before we start the session, do we have any opening remarks from Dr. Soumya? Over to Dr. Soumya.
Thank you, sir. We consider this as a very good opportunity to discuss how to have an academic discussion here. I really congratulate IAP for conducting this session. So this we'll be discussing a journal on the determinants of precocious puberty. The study setting is in China, but the study is still relevant, very relevant in our population too. Every OPD we get more number of children being referred for precocious puberty nowadays. So at least one case every week we get, more than one case actually. So there are many factors which we know and many factors which we are actually unknown to. So this area is a very good area for research, especially in our setting too. So this session will be around 45 minutes to 1 hour session. We'll be dealing in 3 sections. First of all, I'll just brief with the terminologies of precocious puberty and the minimum basic nuances which we need to know about precocious puberty so that we can understand the journal better. And that will be followed by the journal discussion by Dr. Jisna and the analysis of the journal by Dr. Fathima. So without much delay, I am going to may I move forward with my presentation, sir? Just 5, 10
sure, sir. Padmanabhan sir, can we go forward?
No, go ahead, yes, please.
Okay, sir.
Yes, we can go ahead.
Screen. May I share the screen?
Yeah, sure. Sure.
So this is the journal.
Yeah.
Sorry.
Yeah, please go forward.
Yes. So this is the journal we are talking about, analysis of risk factors of precocious puberty in children. So we'll just have a brief discussion about what is the physiology of puberty. So once the child is born, in the newborn period, actually we have 3 puberty in our life. First puberty actually happens within mother's womb. The second puberty, which is called the mini puberty, happens immediately after birth. And then the third puberty is the normal, usual puberty. So the early puberty inside the womb is for the formation of the gonads and the external genitalia. The second puberty, which is more commonly referred to as mini puberty, happens immediately after birth. Why? Because when the baby is born, the mother's estrogen is being suddenly deprived from the child's body. So this sudden withdrawal of estrogen from the mother, that leads to an activation of the hypothalamo-pituitary gonadal axis, leading to an onset of puberty. And for boys, this lasts for the first 6 months, and for girls, it lasts up to 2 years, may last up to 2 years. That's the mini puberty. And after this period, there are many factors from the brain, many neurotransmitters and many neuronal pathways are there. which will come and suppress this puberty till the organism is mature enough for reproduction, so that the growth can occur. So that happens in the pre-pubertal period. And once after the child has achieved a sufficient physical maturity, then the pubertal hormone starts again. This axis becomes active again. So the normal only after the normal usual age for puberty. And so all this process starts from the hypothalamus. Actually, there are GnRH neurons in the hypothalamus, gonadotropin releasing hormone secreting neurons in the hypothalamus, in the preoptic and paraventricular areas of the hypothalamus, that secretes GnRH. That comes to the anterior pituitary, and the anterior pituitary secretes FSH and LH. And this FSH and LH acts on the gonad, the respective gonad, ovary in females and testis in males, to produce the respective gonadal steroid, which is estrogen and progesterone in females and testosterone in males. So that is the puberty, the physiology of what is happening in puberty. And what happens, this testosterone will, as the dictum in all endocrine organs, there is a feedback inhibition too, because these hormones should not be in excess. It should be in optimal range only. So all hormones have a feedback control. Here the feedback control is that the testosterone, this gonadal steroid, will have a feedback inhibition on the hypothalamus as well as the pituitary, so that this is tightly regulated. There are many other factors which determine this puberty. This timing of puberty, that's very interesting and very enigmatic. Very many studies have been conducted on this area. What actually triggers, what actually determines this age? We have many definitions for age of puberty. Before 8 years or before 9 years, we call it precocity. But if we check the secular trend from the time immemorial, the age of puberty has always had a secular trend. It has been younger in the earlier years, and after the era of industrialization, the age has advanced to a more higher age, and now it is again going back to a younger age. We are now witnessing a younger age of secular trend of younger age of onset of puberty. And one of the factors which determine this is leptin, that is secreted from the, why I'm talking about leptin is because leptin is being discussed in this journal. Leptin is a substance which is a protein which is secreted from the adipose tissue, white adipose tissue. This has got a regulatory effect on the kisspeptin neurons and via kisspeptin neurons on the GnRH neurons in the hypothalamus, thereby determining the puberty. Because leptin is a signal to the brain that, okay, this organism has enough fat stores to support reproduction. So, and this leptin, an optimal level of leptin is required for onset of puberty. So, it has got a permissive role on the pubertal axis. Leptin alone is not enough. The GnRH and the pituitary axis is required, but leptin has got a permissive effect on the pituitary and hypothalamus for the onset of puberty. So, the pubertal changes that happens in girls and boys, we all know. Girls develop breast, pubic hair, and axillary hair. We have the Tanner staging for breast and the pubic hair. Then the ovaries enlarge, uterus enlarges. In the bone, there will be advancement of skeletal age. There is a chronology of progression of puberty. First in girls, thelarchy, followed by onset of height spurt, followed by the development of pubic hair. Then comes the peak growth spurt, followed by menarche. And in boys, the first change that happens in boys is the enlargement of testis, followed by penis, enlargement of penile length and girth, and the pubic hair development, axillary hair, etc. And advancement of bone age, skeletal maturation is one integral part of puberty that happens in both boys and girls. So this we have already discussed, the hypothalamus pituitary gonadal axis. And that has this axis has got a simultaneous effect on the growth plate too. The role of gonadal steroids on the growth plate is that at the long bones, during the prepubertal years, growth hormone promotes growth. The long bones will enlarge, the child will attain a height. Then comes the gonadal steroids. That will have a quick spurt of growth. And this spurt occurs, suddenly the child will increase height. And then it leads to maturation of the physis or the growth plate and fusion. Maturation followed by fusion. So once the puberty is complete, the growth plate goes in for fusion and maturation and fusion. Thereby the growth plate is closed and the final adult height is achieved. So puberty is not a de novo event, but rather a phase in the continuum of development of gonadal function and the ontogeny of the hypothalamus pituitary gonadal system from the fetus to the full sexual maturation and fertility. So puberty refers to the physical and endocrine changes, whereas adolescence refers to the profound psychological changes which is happening side by side with puberty in these children. So how early is precocity? What is the definition of precocious puberty? the development of any secondary sexual characters before the age of 8 years in girls and 9 years in boys is now at present considered as precocious puberty definition in our part of the world. This age is different for different population. Caucasians, Han Chinese, all these people have different definitions for according to their race. Then the causes of precocious puberty, it can be classified into two. The precocity can happen from, it can be GnRH dependent sexual precocity or the central precocity, where the puberty happens early because of the activation of all of these axes. Hypothalamus, pituitary, and the gonad has been activated. Just like a normal puberty, this has activated, but quite early. That is GnRH dependent sexual precocity. There can be another type of precocity where this axis, the hypothalamus and pituitary may not be involved, but there is gonadal steroids. The gonad can start developing steroids independent of the stimulation from the higher centers like hypothalamus or pituitary. Like in a case of an estrogen secreting ovarian tumor, testosterone secreting germ cell tumor, HCG secreting germ cell tumor in a male, like that. So it can be a GnRH independent precocity in both sexes, where the gonadal steroid exposure is happening, but the pituitary and hypothalamus are normal. There are other types also, contrasexual precocity, where a male gets exposed to a female hormone and female gets exposed to male hormone. The classical case is congenital lateral hyperplasia. And heterosexual precocity, that's another term for contrasexual precocity. And there are certain normal variants of precocity, where some factors of precocity occurs, the puberty occurs, but not the whole, like a premature thelarchy. The thelarchy happens, but there is no menarche or born age advancement. That is isolated thelarchy alone. Premature thelarchy, there can be premature pubarchy and premature isolated menarche also in rare cases. So the causes depend on the type of puberty. We're not going into very detail of it, but we need to know that the most common cause of precocious puberty is an idiopathic central precocity. So when a girl comes with puberty, we are more relieved that the chances of the cause being more likely to be a idiopathic central precocity, because girls have a normal like a trend for normal variant of precocity that is occurring earlier. Whereas if a boy presents with precocity, then that is very, you should be very careful, because the underlying cause could be pathological, not a normal physiological process. So idiopathic precocity is common in girls, whereas in boys, this is not very common. Boys usually have a more chance for developing delayed puberty, whereas precocious puberty is more common in girls. So GnRH dependent precocious puberty is 5 times more common in girls, and idiopathic is more common. CNS abnormalities versus idiopathic. So the chance is 1:1, being idiopathic or a central nervous system cause in males, whereas it is 1:4 in females. More common being idiopathic cause. And GnRH independent causes of precocity in males include excess testosterone from adrenal due to adrenal tumors or adrenal congenital adrenal hyperplasia. Or it can be an abnormal secretion of testosterone from testis. It can be due to a Leydig cell tumor of the testis or a familial testotoxicosis. That's a condition where the testis secretes more testosterone in response to the constitutional activation of the LH receptor. And or there can be an HCG secreting tumor, germ cell tumor in a male causing, and HCG can act like FSH and LH on the testis and LH and lead to excess production of LH receptor mediated excess production of testosterone from the testis by the HCG. HCG can act like LH on the testis. And in females, the causes for GnRH independent precocity includes the source can be ovary or adrenal. The causes include adrenal tumors, ovary, it can be ovarian cyst, ovarian tumors, or some part of syndromes like Peutz-Jeghers syndrome, where ovarian cyst produces these tumors. So these sex steroids lead to secondary sexual characters. So what are the actions of the sex steroids? That leads to development of secondary sexual characters in the form of breast, pubic hair, uterine enlargement, menarche, and penile enlargement, pubic hair in males. And it also has an important role in bone, lead to skeletal growth and epiphyseal fusion. But we need to know that the testicular or ovarian, the gonadal enlargement requires stimulation from above. That is, the gonadal enlargement occurs in GnRH dependent precocity, because it requires FSH for this, FSH and LH for this gonadal enlargement. So common to both forms of, that is GnRH independent or dependent precocity, common to both is increased gonadal steroid secretion is common, increased height, velocity, and bone age skeletal acceleration, maturation is common, but gonadal enlargement occurs in GnRH dependent precocity. So what happens in precocious puberty? The child will have which will be tall as a child, and the child will eventually be a short adult, because this pubertal spurt happens earlier. We can imagine that the growth hormone curve, the growth curve is like this with growth hormone, and this is the growth spurt that happens with the gonadal steroids during puberty. If this happens here, the final adult will be this. But if this happens here earlier in the height, then the final adult height will be shorter. So if this happens earlier in the graph of the child's growth curve, and the child will not get enough time to grow with growth hormone because of an earlier fusion of the epiphysis, because of earlier premature exposure to gonadal steroids. So these are the points which we need to look into the history. We're not going to much detail because of for favor of time. We need to know the sexual maturity rating, how to examine that, and skeletal growth also. Examination of SMR examination and anthropometry for height and bone age. That is the most important points which we need to do in our examination whenever we face a case of precocious puberty. And we also need to look for stigmata of syndromes and tumors. So this is the Tanner staging. We're not going into much detail of it. This is a testicle. How do we, in males, what do we examine? We examine the testicular volume with the help of Parada's orchidometer, and also we look for stretched penile length. There are normative data for age-related normative data are there. We can compare with this. And skeletal growth, we all know to take height, mid-parallel height, target height, and we can check the bone age using Grulich Pile Atlas or Tanner-White staging for bone age. And we can also calculate the predicted height from the present bone age to assess whether the child requires treatment or not, or whether the child benefit from treatment or not in terms of height. That is the purpose of this Bailey-Pinot chart and predicted height. Okay, so, and this is the last slide. What are the labs that we need to know? Some of these tests are being done discussed in the journal. So first of all, rule out hypothyroidism. Hypothyroidism can rarely cause precocious puberty called Van Weyck-Grumbach syndrome. By TSH can act like FSH on the ovary, and it can lead to TSH-mediated FSH receptor activation of the ovary, leading to ovarian hyperstimulation, large ovarian cysts, and excess of estradiol production from the ovary, leading to a precocious puberty. That's the common pubertal disorder in hypothyroidism is delayed puberty, but rarely hypothyroidism can cause a syndrome called Van Weyck-Grumbach syndrome, where we can develop a GnRH independent precocious puberty by the mechanism we discussed. Then to call it as precocious puberty, according to the labs, we need to have an LH which is more than or equal to 0.3. LH more than or equal to 0.3 international units per liter is considered as precocious puberty. So if you are asked to do only one test, then LH is the test you need to do. Then FSH.
Madam, does it differ according to age, madam? Is basically LH more than 0.3? Does it differ according to the age?
No,
does it
no,
differ
sir.
according to age?
No, sir. Okay, no, sir. This is for determining whether puberty has occurred or not, irrespective of the age.
Fine,
whether
fine.
the child's pituitary has gone in for, the puberty has started at the level of pituitary. So LH more than 0.3 indicates that the pituitary has actually been overcome that suppression and has initiated that pubertal process. GnRH dependent pubertal process. And an estradiol of more than 10 picogram per ml also indicates that onset of puberty, but estradiol is not commonly done to diagnose because the assay, it's a very small picogram per ml, so the lab assay interferences are very common with estradiol. Testosterone more than 20 nanogram per DL indicates that the boy has gone in for puberty. Then we can also, in doubtful cases, you can do an LH stimulation test with a GnRH agonist like leuprolide or triptorelin. And there are cutoff values for each to diagnose, confirm a precocious puberty. Then if you do an ultrasound, you can see there are changes in the uterus and all. There are certain measurements which determines puberty. A uterine length more than 3.5 centimeter means that there is evidence that the uterus has been exposed to estradiol. And the uterus to cervix ratio more than 1:2. And presence of endometrial stripe, all these shows that the uterus has been exposed to estradiol and the puberty has started. And an ovarian volume of more than 2.8 ml is suggestive of puberty. And ovarian cysts, if you have multiple ovarian cysts, that's also suggestive of a puberty. An MRI in cases of central precocious puberty, we do an MRI to rule out other causes of puberty, like other causes of GnRH dependent puberty. Most common are hypothalamic hamartoma and optic glioma. All those tumors can cause precocious puberty. So we do an MRI in case of a GnRH dependent precocity and to check for these conditions. So I hope we now know what is puberty, what to look for, and what are the labs that determine puberty. Now we'll move on to the move on and see what they have done in the journal. I hand over to Dr. Jisna for presenting the journal. Thank you.
Thank you, Dr. Soumya. Over to Dr. Jisna.
Good evening, sir.
Yeah, please continue. Good evening, madam.
I will say them.
Can I share my?
She already shared. Yeah.
Sir, can you see the slides?
Actually, no, Jisna. I think we will have to share that again.
Okay.
No issues. You can do
Okay.
that. We have time.
Great.
Yes, now it is visible.
Okay. Good evening, all. I'm Dr. Jisna Najeem, Pediatric Resident, Cosmopolitan Hospital. Today, I'm presenting a journal which has came in BMC Pediatrics on 2023. It is the study is about analysis of risk factors of precocious puberty in children. Background: purpose of this study is to explore the related factors of precocious puberty in children. Introduction. Precocious puberty refers to the early emergence of secondary sexual characteristics in children, in which girls having secondary sexual characters before the age of 8 or menstruation before age of 10, boys having secondary sexual characters before the age of 9. In girls, secondary sexual characters are breast development, pubic and armpit hair development, and pelvic widening. In boys, secondary sexual characters are testicular enlargement, penile enlargement, and development of armpit hair. According to pathogenesis and clinical manifestations, precocious puberty can be divided into two. As ma'am told, it is central and peripheral. In recent years, studies have pointed out that the incidence of precocious puberty in children is increasing year by year, and the trend is getting younger. So, precocious puberty in children will lead to increased hormone secretion in children, which will affect their psychology, height, advancing bone age, resulting in short adult height. And there is also a risk of high blood pressure, diabetes, obesity, and infertility in adulthood. The underlying etiology could be central nervous system tumors like hypothalamic hamartoma or pituitary adenoma. Previous studies showed that occurrence of early puberty in children may be related to gender, leptin, daily activity time, and all. The result of each study are not completely consistent. Therefore, it is necessary to identify the relevant factors that can cause precocious puberty in children as early as possible and prevent the risk factors so as to avoid the adverse effects of precocious puberty in children. Based on this, these studies have explored the relevant influencing factors of precocious puberty in children. Clinical data here, 1,239 children who underwent physical examination in this setting from January 2020 to December 2022 were analyzed, including the precocious children and 1,041 normal children. According to the 198 precocious children and 1,041 normal children, 205 normal children were selected and the remaining 836 normal children were excluded. They were divided into precocious group and normal group, and the general date of the two groups were recorded. So here, total 1,239 children were taken. In that, 198 were precocious children and 1,041 were the normal children. Age-matched normal children, according to the precocious children, were 205, and the other 836 normal children were excluded from the study. So, diagnostic criteria for children with precocious puberty is girl less than 8 years and boys less than 9 years having secondary sexual characters. In girls, they have taken body shape changes, which they haven't mentioned what all body shape changes have taken. Then breast enlargement, axillary hair and pubic hair, areola becoming more than 3 centimeter, and menarche achieving more than before 10 years of age. In boys, enlarged laryngeal node, beard or pubic hair, and testicular volume more than 4 ml was taken, but they haven't taken like how many criteria to be fulfilled to taken as a precocious child. Inclusion criteria for a precocious child, those who meet the above diagnostic criteria with the normal mental status was taken. Inclusion criteria for normal children, all who were examined in this study setting was taken, and their age matched that of the precocious children. Those who do not meet the diagnostic criteria for sexual precocity, and those who have no other diseases with abnormal growth and development, and parents who have the willingness and ability to participate in the questionnaire was taken. Exclusion criteria include those with heart, liver, and kidney disease, patients with tumors, those with endocrine or metabolic diseases, those who are combined with infectious diseases such as tuberculosis, children with precocious puberty who have clear causes such as taking contraceptives and breast creams by mistake, and those who combined with the organic basic diseases of central nervous system like congenital hypothyroidism, congenital adrenal hyperplasia. This research protocol complies with the relevant requirement of the Helsinki Declaration of the World Medical Association. The study protocol was approved by the Ethical Committee of the Hebei Medical University. Informed consent was obtained from their parents and or legal guardians before enrollment. Method: all medical and nursing personnel in this study have been trained in profession and professionally examined before taking up their post. All the data of the subjects and parents are confidential and have signed privacy and confidentiality clauses. Data collected from children include age, sex, height, BMI, waist circumference, secondary sexual characters according to the Tanner staging criteria, living environment, and sleep time. In data collected from parents include educational background, height, mother's menarche time, and childbearing age of the parents were recorded. And these are the Tanner staging which was taken for the study. For this is the breast stage for girls, pubic hair stage for girls, external genitalia stage for boys, and pubic hair stage for boys. Serological indicators: they have taken 5 ml of fasting venous blood from all subjects and centrifuged and sent for examination. The kit detail of each assay were mentioned in the study. For estradiol, FSH, LH, and leptin. Determination of bone age: the height and BMI were measured by the same endocrinologist and measured according to the Grulich-Pyle Atlas method and evaluated by more than 2 specialists. If the error was more than 6 months, the third specialist should participate. Observation indicators: the general data of the 2 groups were recorded. Statistical analysis: SPSS21 software was used to analyze the data and Excel was used to establish the database. The measurement data conforming to the normal distribution was expressed in X bar S. The overall comparison of the data of each group performed by one-way ANOVA, and the pairwise comparison of data between groups and within groups is performed by LSD method. The counting data is expressed in percentage. Chi-square is used to check and compare. Single and multiple factor analysis logistic regression was used to analyze the influencing factors of precocious puberty in children. So, in this study, baseline characters were analyzed for matching the group. Then they have compared each variable determining the puberty between the group for any significant differences using one-way ANOVA, and significant variables were further analyzed using logistic regression and risk of association using odds ratio. Now I will go to result. Comparison of general data of each group. There was no significant difference between 2 groups were seen for height, BMI, birth weight, gestational age, birth order, birth mode, use of adult skin or cosmetics, father's height, mother's height. As in for these variables, the p-value was more than 0.05. There were statistically significant analysis between the 2 groups was seen in sex, bone age, daily exercise time, estradiol, FSH, LH, leptin, mother's menarche time, living environment, consumption of nutritional supplements, consumption of food containing pigments and preservatives, consumption of high-fat food, and sleeping time, as the p-value was less than 0.05. So now I hand over to Dr. Fathima for analysis of this study.
Okay, thank you, Dr. Jisna. Over to Dr. Fathima.
Good evening, all. I am Dr. Fathima, Junior Resident, Cosmo Hospital. The analysis of the journal will be dealt by me. Here, we have used one-way ANOVA logistic regression for the analysis of the study. So I will give a brief introduction on the studies used. ANOVA, it is analysis of variance. It is a statistical method used to compare the means of 3 or more independent groups to determine whether there is a statistical significance difference among them. ANOVA, we have one-way ANOVA and two-way ANOVA. In the study, we have used one-way ANOVA. One-way ANOVA is used to compare means of 2 or more groups based on one independent variable. In this study, the two groups taken are the precocious child and the normal child, and the independent variables are age, gender, child height, etc. In the two-way ANOVA, we use two independent variables. This is a comparison of general data of the two groups. We have taken 198 precocious child and 205 normal group, and these variables are assessed using chi-square and t-test appropriately, and the p-value was derived from that. In the study, the gender, age, child height, BMI, birth status including birth weight, gestational age, birth order, parity, birth mode of natural labor or C-section, use of adult skin or cosmetics, father's height, mother's height, maternal birth age, and parents with college education or above have an insignificant p-value of more than 0.05. The p-value was significant for the born age, daily exercise time, second factors including estradiol, FSH, LH, leptin, early mother's menarche time, that is less than 12 years, living environment in chemical industry zone, consumption of nutritional supplements, consumption of food containing pigments and preservatives, consumption of high-fat food, and reduced sleep time. The chi-square and the t-test, the variables used are the categorical variables for the chi-square test, that is the fixed variables, for example, gender, mode of delivery. For the numerical continuous variables, we have used the t-test. P-value, it is the significance of association. If it is less than 0.05, it is statistically significant. It is more than 0.05, it is not statistically significant. The significant variables were further analyzed using logistic regression to know the risk of association. We will give the introduction of the logistic regression. It is used to assess the relationship between one or more predictor variable and a response variable. It's a diagrammatic representation of logistic regression analysis where we have taken one or more independent variable. Here example, reduced sleep time, reduced daily exercise time, early mother's menarche time, and the probability of the event occurring was analyzed. Here, the event is precocious child or a normal child. There are two types of logistic regression, single factor logistic regression and multiple factor logistic regression. In single factor, we are using only one predictor. In multiple factor, two or more predictor can be used. In single factor, there is no confounding. Confounding refers to a situation where the relationship between an exposure and an outcome is distorted by a third variable. In multiple factor logistic regression, they will adjust for confounding. Single factor will give the crude odds ratio. Multiple factor will give the adjusted odds ratio. And single factor is used for preliminary analysis. Multiple factor for final model. An example of single factor in this study was a female gender with an odds ratio of 3.018, more likely to have precocious puberty. And after multiple factor logistic regression, they found that it is still significant after adjustment. For the single factor logistic regression analysis, these are the independent variables which are used for the testing. That is female gender, born age more than 10 years, reduced daily exercise time of less than 0.9 hour, elevated estradiol more than 66 picomole per liter, elevated FSH more than 6 units per liter, elevated LH more than 3.5 units per liter, elevated leptin more than 8 microgram per liter, early maternal menarche less than 12 years, living in chemical industry zone, consumption of nutritional supplements often, consumption of food containing pigments and preservatives often, consumption of high-fat food often, and reduced sleep time of less than 10 hours. The dependent variable is child's precocious puberty. This is the single factor logistic regression analysis of precocious puberty in children. The variables used are the mentioned above, that is the independent variables which are used here. We will analyze with the beta, that is coefficient of regression, standard error, Wahl's chi-square value, odds ratio, and the p-value. Beta, the regression coefficient, it is a value that represents the relationship between the predictor variable and the responsible variable in a regression model. In simple linear regression, the regression coefficient is the slope of the regression line. Beta can be positive or negative. Positive coefficient indicate a positive relationship. As the predictor value increases, the response will also tend to increase, and a negative coefficient indicate a negative relationship. In multiple regression, these coefficients represent the change in response variable for a 1 unit change in that specific predictor, while all other predictors in the model are held constant. This is the independent variable and dependent variable on x and y axis, and it's the line of regression, and the data points are, this is just an example. The terms used in the table, the standard error and the Wald chi-square. Standard error is the standard deviation by root of the sample size. The definition is standard deviation of a sample population, which will measure the variability of the precision. In Wald's chi-square, beta coefficient of regression by standard error, the whole square, which will assess the statistical significance of individual predictor variable and tested if predictor is significant. Coming to the table of single factor logistic regression, here they have given the odds ratio. The highest was for the consumption of high fat food, followed by living environment, that is chemical industry zone, followed by advanced bone age and elevated estradiol. The least odds ratio was for mother's menarche time and consumption of food containing pigments and preservatives. After the single factor logistic regression analysis, they have done the multiple factor logistic regression so that the confounding will be reduced. The same independent variables are taken here also, and they have charted according to the same, that is regression, standard error, chi-square, Wald's chi-square, odds ratio, and the p-value. From the multiple factor logistic regression, the analysis showed that the odds ratio was more for the elevated LH. This is the risk factors according to descending order of the odds ratio. That is, first it comes the elevated LH, then consumption of nutritional supplements, positive family history, early mother's menarche time less than 12 years, living in chemical industry zone, then comes elevated FSH, reduced exercise time, elevated leptin, elevated estradiol, advanced bone age, female gender, consumption of high fat food, and reduced sleep time. These are the risk factors which they analyzed and come to the risk factors, which are form the risk factors after the study. Coming to the discussion, with the improvement of living standard, precocious puberty is increasing nowadays. The height, weight, bone age of the child with precocious puberty develop rapidly, leading to early bone age development, early fusion of the epiphysis, and the shortened growth period. Thus, the final height of the adult will be affected and lead to dwarfism. This increases the risk of cancer, particularly uterine and breast cancer, and changes in mentality caused by sexual development will increase the psychological burden of children and cause social problems such as early sexual behavior of the child or juvenile sexual crimes. Domestic research point out that the age of the children's precocious puberty has a tendency of appearing at younger age. Among them, idiopathic central precocious puberty is the most common, accounting for 92% of the precocious puberty. Children's precocious puberty has become the major second problem that plagues children's healthy growth. Therefore, the prevention and treatment of precocious puberty has become a hot issue in the clinical research at this stage. Therefore, it is necessary to analyze its influencing factors to prevent the occurrence of precocious puberty. Sumya et al. Point out that the frequent consumption of nutritional food and mothers menarche age less than 13 years are independent factors which affect child's precocious puberty. Hakun et al. Point out that LH, FSH, estradiol, diet, and living habits are the independent risk factors affecting precocious puberty in children. Li Fang and other researchers point out that the child's growth and development are affected by various factors. The current research have confirmed that the incidence of precocious puberty in girls is significantly higher than in boys. Less exercise time per day will lead to fat deposition in the body, stimulating hormone secretion and causing sexual precocity. The estradiol formed from the corpus luteum and ovarian follicle is an important indicator of normal sexual hormone level and function. LH and FSH play a synergistic role in maintaining menstrual cycle. LH act on the overheat to synthesize estrogen. Estrogen act on the growth plate, resulting in accelerated growth and advanced bone age. Leptin is a pleiotropic hormone secreted by white adipose tissue, which will regulate the secretion of gonadotropin-releasing hormone and has a direct physiological regulation on ovarian function and promote endometrial thickening and volume increase. Consumption of nutritional supplement and high-fat food will lead to excessive energy intake, excess energy will be stored in the form of fat and this thus will affect the endocrine. A short sleep time will affect the normal work of the pineal gland, the secretory organ in the brain, thus inducing sexual precocity. Gongda et al. Point out that the children can increase the risk of precocious puberty due to eating contaminated food, high leptin, and short daily exercise time. Moochwitting et al. Point out that the occurrence of precocious puberty in children is related to living habits, eating habits, maternal age at menarche, estradiol, FSH, LH, leptin, and other factors. These are the recommendations from the study. Clinicians should pay attention to child's gender, born age, exercise habit, estradiol, FSH, LH, leptin, mother's menarche time, living environment, eating habits, sleep time, and other factors to assess the occurrence of precocious puberty. It is important to detect born age, estradiol, FSH, LH, and leptin level in children every year. Parents should reasonably arrange children's eating habit, exercise habit, and avoid high-fat diet to reduce excessive accumulation of fat. In addition, suitable living environment can also prevent the occurrence of premature puberty in the children. The limitations of the study. First, this study is a retrospective observational study with a small sample size, which may weaken the generalizability of the result. Second, some characteristic data spans too long and may be inadequate, which may introduce bias. Third, some precocious puberty symptoms are not obvious, which may lead to selection bias. In the next study, they wish to conduct a prospective study with a large sample size to explore this topic. Conclusion: child's gender, born age, exercise habit, estradiol, FSH, LH, leptin, mother's menarche time, living environment, eating habit, sleep time, and other factors are closely related to precocious puberty. Reminding parents to actively prevent related factors in clinical practice is helpful to prevent the occurrence of precocious puberty in children. Handing over to Dr. Jisna for the review of literature.
I think we can skip that part. Is that actually needed, Soumya? Should we go for that part, because we already have some discussion on.
Yes.
Can you just skip? Just scroll through that and just tell
one
the
or two studies
important
from
points.
India only, sir.
Yeah,
One or two studies from India only.
Yeah, if it is significant, you can just mention, Dr. Soumya, please. Yeah.
As we have discussed about the Chinese population, these are some of the studies which were conducted in India, which showed similar trend for precocious puberty. This was a study conducted in Maharashtra. Here, age of menarche and socioeconomic status are linked. Like that is, higher socioeconomic status was linked with lowering age of menarche. Similarly, diet which is rich in high calorie and rich protein diet, age of menarche was earlier. Similarly, a percentage of girl attaining menarche was more seen in children undergoing no regular exercise and or physical activities. This was a study conducted in Kollam by assistant professor and statistics in Department of Community Medicine. Here, two schools were taken from urban, one from urban area and one from rural area, and there was a statistically significant difference was seen in the age of precocious puberty in the urban area who were having like industrial zone, and similarly children who were taking high protein food like fish and meat was having higher incidence of precocious puberty. And they have also checked for the physical activities in the children that was also linked to earlier precocious puberty. This was also a study conducted in Delhi. Here, overweight and obese children showed 6 months earlier onset of thelarche and menarche than those with a normal BMI. This method. Thanks.
Okay, actually, I'm sorry. This was very important. Actually, it was very useful also, and I should take the freedom when my seniors are available, because this was one of the most, academically interesting and one of the best presentations that we had in the journal club. I think Benno will agree with me, because such beautifully the epidemiological terms has been explained, and if not the best, it should be among one of the best actually. But that is my opinion. For expert opinion, we should go to Dr. Ramakutty sir. To Dr. Ramakutty sir.
Hello, am I audible?
Yes, sir.
Yes, sir.
Actually, I have a little difference of opinion in the sense, of course, this topic is very important for clinicians and very important from the population point of view because it's a major problem maybe. And it's maybe not in numbers, but maybe to the people affected, it's a very serious issue. So that way, but I was surprised that this paper got published because it's very poorly written. If you look at the language and the syntax and it's not very poor. Usually you don't get such articles in the international literature. I could point out many of those, but I don't want to. Even they have not expanded, at least I didn't find some of the short forms. They have just used it, assuming that everybody knows what is E2, what is, of course, LHSFH I could guess because I'm a doctor, but the people who read from another field should understand what it is all about. So whenever you use a short form, this is something of a disease with doctors, I'm sorry to say. They just use technical jargon and acronyms without explaining what it means. So the rule in any written publication is the first time you use a short form, you have to explain what it is. Or you have to give a separate glossary of all the terms that you have used. And I don't think they have done that. But anyway, I mean, I just had one reading. Maybe they have done it somewhere in the appendix or something. Apart from all that, one major glaring thing that I noticed and nobody pointed out. So I don't know what design the study is. Have you any idea? Can you? I can guess, but have they said anywhere?
So this
You also didn't discuss that.
It's a retrospective actually cohort study, sir. Retrospective cohort.
Is it
They
a cohort?
compared two cohorts.
Is it a cohort or a case control?
Okay, more of a case control. More of a case.
You can't
call it actually.
Is a cohort or a case control? I thought it is a case control analysis of a cross-sectional study.
Here it's they can't be called a proper control because they have the population they chose
Exactly,
to
that's what I'm
control
saying.
is
It
not
is
a proper control actually.
Not a case control study. They have not done a case control study. That is what they should have done if they wanted to look at the risk factors of precocious puberty.
Yes, so they're just a descriptive study where they've taken.
That's right. That's a cross-sectional study.
Cross-sectional analysis only. Sir.
But in the cross-sectional data, they have compared the puberty, precocious puberty with, but my point is they have not stated that and you have also not stated that. At least you could have said that there is a ambiguity regarding the design. That is how you criticize the study. You can't just accept whatever they are saying, isn't it? So that is one important point. And if you look at the data also, I had some problems. One is that if you look at gender, for instance, that big table, the chi-square says it's not significant. And then their odds ratio is significant. I really couldn't understand. If you could understand, you can please explain how that came about. But to me, it is very strange.
Gender was significant, sir, and that's where they
take the table. Take the table and the chi-square at the top.
The number is
sir, I was about to give a conclusion note about this journal actually, sir. Why we have chosen this journal before the discussion actually, because we wanted to discuss about the content which they have been discussing and
no, Soumya madam, it is perfectly okay. That is why we do a journal
yes,
club.
sir.
Sir is not
No,
criticizing.
No, I'm not
so we are actually analyzing the journal
I
article only. So we have actually this is what exactly which is needed.
You have
So
every right to
don't worry, it's just a.
this is like an exercise for the PGs actually to take up a not a book journal and criticize them. So they have actually made them, a note of what are the limitations of the study. Actually, not the limitations, a critical analysis of the points where they have actually gone wrong. Even the grammatical errors a number of grammatical errors are there in this.
Yes. I noted that.
And yes,
I noted that. The spelling issues also. Any idea about the sir's question, Dr. Soumya? Any idea about sir's question? Sir was asking about some chi-square and
yes, sir, there is a flaw in that. The chi-square is said as the chi-square value is insignificant, but in the text they have written that it is significant and they've taken that gender for further logistic analysis.
Yeah.
That's a different. And they have done ANOVA here. They could have done a t-test easily. Students.
The thing is that they have only two groups, and
only two groups, and they have done ANOVA.
But when you can excuse that because if you look at the ANOVA, the t-test is a special case of the ANOVA in the two groups. So that way it is not wrong. T-test is just ANOVA in two groups. So that way statistically it is not wrong to say call it an ANOVA. But usually we don't say that. We usually call it a t-test. So those kinds of issues are there, but I think the topic is important, and I think
And
it
the
is something that
inclusion criteria is
pediatricians should
also not,
discuss.
even the inclusion criteria is not clear, sir.
Yeah,
They
exactly.
have discovered how many factors they have taken, either one or the other or multiple, all the factors are required for inclusion that they have not specified actually.
So it gives me the impression of a very casually done study. I don't know if that is true. That is my opinion, of course. You can point out if I'm wrong.
Okay, sir.
I mean, that's all.
Yes, sir. We will come back to you, sir. I think we will go to Dr. Padmanabhan, sir. Padmanabhan, sir. Sir, you are muted, sir. Yeah.
I was also confused on certain things, like they have said taking nutrition supplements. What do you mean? I mean, how much do they take? And which category they go when you take? If you take 10 days vitamin B, does it become a nutritional supplement? That is one thing. And they have said chemical environment. I don't know in China how they make out, maybe urban and rural. The most important thing with the precocious puberty, which is alleged now, I don't know, the endocrinologist can say, is the meat which you eat, chicken or anything where you are injecting hormones. Am I right? Because now there is a little worry about it, that many hormones are given to animals so that they grow fast, chicken especially.
I think there is some
Yeah.
term called
That is
endocrine
something which
disruptors.
is not looked into in this. And they have said that they included normal children first and then they excluded. On what basis were they excluded and what basis was the control normal children taken? Anything was there? I'm not sure. And in between, I heard that something called an enlarged laryngeal node. What does it mean?
Yes. I was
That
also
I didn't
curious about
understand.
that actually.
In
And the
boys,
word
they might have
also.
meant the
They
Adam's
were telling.
apple actually.
I think
Laryngeal
that is
concept,
part
but
of the
that is
language
not.
problem. They're not very familiar with English, I think. Could have just said Adam.
They might have meant the Adam's apple, but it is not a technically used clinical examination finding to define puberty. It is not used in SMR staging or anywhere else.
Yeah.
And another thing I would like to point out is in precocious puberty, wherever I have read the articles, two things they are concerned. One is the social status of the family, because they tend to eat more, less exercise, etc., which is considered very significant. The other is the eating animal meat, which is injected with hormones. These two things do come into the study in this. As
So
far
can
as
I give an explanation on that? So they in this study, they have mentioned about high fat intake as one factor, but how much fat to qualify as high fat, how they have segregated the children based on that, it has not been done. But sir, to take that, so as you have told, many patients usually ask this. There's a concept that meat injected with like hormones can lead to precocious puberty. But so that is a scientifically, that is not the thing happening, sir, actually, because all of these hormones are heat labile. So if you inject testosterone or estradiol into a chicken and then we cook it, that gets inactivated. That's why the oral absorption bioavailability is very low for even the tablets that we take. So the hormones is not the culprit, but rather the certain protein, high protein in the animal protein. So the animal protein like red meat is a culprit. The certain factors in those the amino acids in that can lead to early activation of the hypothalamic pituitary axis. It is the other way. And high fat is a very well-known factor for high fat intake, especially in the earlier years of life, lead to exposure to high fat diet. That is also proven in many studies factor for precocious puberty. And another thing is that many endocrine disruptor chemicals, exposure to those have been suggested, like the bisphenol A, BPA, which is very commonly present in plastics. Then second is phthalates. Phthalates are also present in plastics. Then parabens present in cosmetic products. All these have, there are enough data on all these products causing precocious puberty. So most of our children, if we see, they take water to school in plastic bottles. They take lunch in plastic lunch boxes. So the exposure to plastic, the food we order, they come in plastic boxes, especially heated. So hot food coming in plastic box. So all these are not BPA and phthalate free. So even if they say that most are food grade. So such exposure is one important factor that is more for higher socioeconomic status. This is not there for rural population. That is one factor. Then urban children have more exposure to high fat and high protein, this red meat protein food. That is another factor. Obesity is a very well-known factor because when we have increased fat stores, the leptin secreted from the fat stores is higher. So leptin will lead to an early activation of hypothalamus, leading to puberty. And in obesity, there is a hypothalamic inflammation going on also. That can also lead to a early activation of pubertal axis. So all those factors which lead to obesity can lead to that.
Do you get a lot of such cases? I mean,
very common nowadays, sir. Even after the COVID, 2 to 3 years after COVID, the number of cases which are coming has increased at a very high rate. Now, presently for the past 6 months, I think there's a alarming rate of increase in the number of precocious children being referred to the maybe the
generally, I mean, this is my
vacation
impression.
bias is also there, sir. April, May vacation bias.
Your reference bias might be there. But what I'm asking is, generally, I thought the younger people are getting taller, and I mean that probably goes against this, isn't it? The secular
Yes,
trend.
rightly pointed out, sir. The younger children are more taller nowadays. So we are going to face a shorter adult population in the coming years. All these children, when they grow up, they're going to be shorter adults.
They're getting, I mean, their early puberty, they should end up being shorter, isn't it?
They end up being shorter, yes, sir.
And another thing I wanted to ask is, there was a notion in the olden, I think I remember reading long ago, that it is also related to the puberty is also related to the latitude in which you live. Like if you live in a colder climate, you get late puberty, and in the tropics, you get early. Is that still true, or is it?
Yes, sir, that's also a concept. That's the early studies are there, which shows that living in cold climate that has a delayed later onset of puberty, and tropicals with warmer climate have earlier puberty. That's true, sir.
Dr. Soumya, but this BMI has been, I mean, not considered, I mean, significant in this study, right?
Yes, sir. BMI was not significant. That's there. So maybe the
in this study, the BMI was not.
There's a poor selection.
Yeah, that's what, sir.
Poor selection of cohort.
Yeah, but sir is telling whether this BMI is related to the fat consumption. I mean, what percentage of BMI increase could be as exogenous fat? Can it contribute to BMI? That is what I was.
Exogenous fat, pardon, sir? Yes, sir. Excess
fat intake.
Fat intake can lead to obesity and an abnormal BMI. That can lead to, and BMI is not
but actually. But in this study, BMI was not.
BMI was not significant.
In this study, BMI was not significant.
Not significant. In this study, it is due to a poor, poor selection of groups. But we can justify them in another way, saying that BMI may not be a good predictor of adiposity, even in adults too. So we are a population, different South Asian population, we have a different kind of adiposity. Our adiposity is, we can have lean obese phenotype where the fat is only stored in visceral area and the other areas can be. So with the normal BMI itself, we can be obese. So that is very common for our population, South Asian. So that can also explain.
Madam, is there any particular reason for any secular trend, madam? Is there a particular reason? I mean, why this happens? Is there any theory for that actually?
From what I have read from a public health perspective, from a public health perspective, from what I have read, is generally is that nutritional status is getting better and better all over the world.
But sir, but the point is, sir, now the things have changed actually. People are not, I mean, good income people are not eating uncontrolled and all. Actually, they are more concerned with their health. Most of them are dieting. Most of them are going to a gym and exercises. I mean, there is a slight change in the scenario right now, actually, madam. That was, and another thing also, madam, this increased hormone level is actually a significant a sign that precocious puberty is going to happen. Now that cannot be taken as a predictor, right? It is actually the reason for the, it is actually the effect of the.
That's also here in this group. They have actually taken many things like bone age, LH, estradiol. All those are actually signs of puberty, not predictors.
Signs of puberty.
Associations.
So only thing I have found out. Yeah, so only thing we have found is that some industrial areas, some consumption of some food and all those things are the only, I mean, those are been already a bit of type of established things which lead to puberty. And of course, exercise. But similarly, they have not mentioned how much exercise, how many times a week exercise, and what type of exercise also they have not mentioned actually.
If you look at the
And we think we have
slide
to.
which they showed, recommendations, the last one or so, if you look at that, all those things you could have said even without this study, right?
Yes, sir.
So what did this contribute? That is a good question to ask.
Anyway,
This
let
study
me
is
tell
just
you
an
one
Sarah.
thing.
example for this.
Yes.
Just
This
an
was a
example
very,
for
very knowledgeable thing for me. Actually, Soumya's
Yes.
explanation was outstanding. But
You know,
the journal
it brought out a lot of things. I mean, we could discuss this. That is a very
yeah,
important
because of our lack of knowledge also.
Presentation was good, sir.
that is true.
But journal itself, I thought from the beginning was substandard. Anyway, and good you selected it, because we want you to select journals which are critically analyzed by experts like Ramankutty, who says that this is the reason. This is what I tell my PGs also. Some of the articles which come up in very good, which we consider as very high journals, which at least my generation doesn't know to analyze. I can find the next generation is doing much, much better.
Yeah, that is true.
Somehow it is not possible for me to now learn it. And this is what comes out of it. Anyway, thank you very much. Very good.
I think they have done a
Sir,
good job.
yeah, so there is one question. Sir, please, sir. Please, sir. There is one question, sir. Early puberty is said to have positive correlation with internet use and watching uncensored contents, especially in boys. This study has not considered the psychological aspects. There is one question asked by Dr. Shija.
Is there any study on that?
Actually, I'm
No, sir, it's
aware of
a
many such
theory only,
studies, sir. So there is no scientific explanation for such a thing, sir. So it can
But
be.
what about the? I mean, they'll be in front of the TV. I mean, the laptop only. No, what do you call that?
That
They'll be
sedentary
sitting continuously. That
activity
can be
can
sedentary. Yeah.
maybe that is a confounder, sir. Sedentary
confounder,
life
correct.
is a confounder.
Spend a lot of time in front of a screen, then you're sitting still and you're getting fat. So very difficult to separate the effect.
Yes.
Ramkutty sir, what is this Helsinki Declaration of World Medical Association?
The
Sir? We
Helsinki
have only heard about
Declaration
this.
is the, if you read the history of ethics in medicine, they started with the Helsinki Declaration, after the World War, in which Germans did a lot of human experimentation and all. After that, of course, there was first of all there was a Nuremberg conference when they said all this was wrong.
Yes.
Then there was a New England Journal of Medicine paper which said that even in spite of saying all this, people are still doing all sorts of things. And then that is when they got together and they produced this Helsinki Declaration where they set out these principles of ethics, ethical conduct of human studies, where what is the 4 principles of ethics? There is beneficence, non-maleficence, justice, and autonomy. Beneficence means whatever you do, whatever study you do, it should be for good of the patient. You cannot do a study, establish something bad, or to. Non-maleficence is the reverse of that. You cannot do anything harmful. Autonomy means the patient should agree. Whatever is being done, they should agree. And justice means, they should get a fair deal. Some people should not be favored, etc. So, this is very short explanation. So, Helsinki Declaration is supposed to be the first bedrock on which all the further developments on ethics committees came. So, they always quote that just to show that they have done everything properly. I don't know whether they have. But usually, you see, for instance, these are all young children, right? Right now in the Indian situation, if you do a study on children of this age, you are supposed to get a consent on the parent as well as an assent from the child. They should agree. Apart from independently from the parent. So they have not said anything about that in this.
Chinese study. And
I think Dr. Soumya.
What human rights there? See, regarding this ethical study and all that, I mean, is it ethical to mix various systems of medicine? Is there any Helsinki or any guidelines regarding that? When you practice medicine, can you mix multiple? That's what the government of
You
India.
cannot, in the sense, no, so if you are going to do a study, you should stick to you whatever you know. So, for instance, none of us are qualified to prescribe an Ayurvedic product, so we shouldn't be venturing into those areas.
But when the
I think
government and the
if you are an
PGI Chandigarh
Ayurvedic physician, you can do that. Huh?
when the PGI Chandigarh itself is going to come out with an basic minimum course, which will contain mix of all these medicines, with which has no evidence based, you are mixing it together. How can it be considered as ethical? I don't understand that. Should not the World Health
I
Organization,
personally think it is unethical, but that doesn't mean anything. The
the
government.
World Health Organization is supporting it. They have got a whole department for integrative medicine, not only for practice but for teaching. How can that be ethical when the WHO is now himself going unethical? That's my question.
Their justification is that people are using this anyway. So how can you
That is
deny
not.
that?
That is not.
I don't know. I'm not defending. I'm not part of
Yeah,
that.
but I'm trying to tell you, this epidemiologists and high statisticians whom you know has brought about these ethical, unethical, etc. Shouldn't they get involved in this also? Because this goes against patients' interest very badly. I know many of my relatives. Now, because the government is supporting other systems of medicine, they go with that treatment for
See, in this
diabetes.
question, I will tell you a story sometime several years back when Dr. Ramdas was there. He was, your classmate. So one Ayurvedic product which is very popular in Kerala, and that person who's owner of that, he came forward and he wanted a study to be done. He said, "You can do whatever, you can design the study." So Ramdas was very excited, and we got together and designed a study. The thing is that it was something they give for asthma. So and first thing he said is, you go and analyze my product and find out if there are steroids or whatever. And then it was given to the pharmacy department, and I don't think they found any steroid there. But then the next step was doing a patient study. But then this question arose whether we can actually, knowing that we are trained physicians, how can we prescribe this product when asthma has a very effective treatment? So we kind of backed out of that. We said we cannot do that because it's unethical to deny the proper treatment to the patients.
From 1990 onwards, if I am right, you can tell me, the American pharmaceutical companies had pumped in billions of dollars to find out evidence for other systems of medicine, and they found nothing.
That is true. There was a facility in Bombay which I was saying it was owned by Sibagegi. They analyzed a lot of Ayurvedic products, lot of herbal products. Finally, they came to the conclusion that they cannot make any profit out of this properly because
not profit. They didn't find any evidence.
Yeah, no effective element, no effective agent was found out. So they packed up.
Now, if I interfere, apology for my interference. Actually, we have tangentially gone to the ethics and all those things. Actually, it was a nice discussion though, but for lack of time, I think we should continue this. And coming back to the topic proper, what I would like to tell is that as I told before, this was a meticulously presented, and this was a type of presentation I would like to have in journal clubs, because explaining everything in every epidemiological factors and all the things and all. And it was a very significant topic also, because there are very, very preventive factors as far as we came to know from this discussion, which can because precocious puberty has got some implications, psychological and physical, later in the life. So some preventive factors, if it is there, we can consider, we can discuss about those things and discuss about how to control all those things and all. That is what the Journal Club is not about presenting the perfect article and getting, closing like that. Actually, we usually present all type of articles, and the exact reason for having Ramkutty sir here as the expert analysis is the reason. Just what things like this. Actually, we have taken articles from Lancet, BMJ, and Indian Pediatrics, but it is not as it looks at it first. That the visual it is. When we analyze only, we come to know that some articles has flaws, articles have some issues at all, and it all depends on the how well we study the article and present it. And I think this was an excellent session. And actually, the topic is open for discussion. We have other doctors. Dr. Benno is there, Rosemary is there, Dr. Rekha Madam is there. So if anybody want to contribute anything or to discuss anything, they are free to do so. And also, Soumya Madam, if you want to add anything, Madam can do that also. Dr. Benno? Dr. Rose? Yeah, I think. Dr. Rekha, anything? Okay, Soumya, any closing
I joined
remarks?
in quite late, so cannot comment much.
Yeah,
Wonderful
please.
discussion. I'll be listening to the rest from the YouTube.
Thank you, madam. Dr. Soumya?
Yeah, going to the, if there are no more questions, I'll just conclude by telling one.
No, you want any concluding remarks or things you
yes.
want anything to? Yeah, please tell.
Yes, sir. About the precocious puberty. So, identifying precocity is important for us, and more than that, now we have more cases of precocious puberty. We can be on the lookout for. We can be giving advices to the children right from early years itself for prevention of this early puberty, because this has got a impact on the metabolic life later. Precocious puberty is associated with early increased incidence of metabolic diseases like diabetes, hypertension, dyslipidemia, coronary vascular disease, etc. in later life. Maybe.
But as far as idiopathic puberty is concerned, precocious puberty is concerned, what is the management like? Do we have anything? Do we have any particular management? If there is some cause, secondary cause, then we can manage that, right? For idiopathic precocious puberty, how are we managing actually?
Yes, so central precocious puberty we give for appropriate patients. We can actually halt the puberty by giving GnRH agonists. GnRH agonists, long-acting leuprolide depots are leuprolide or triptorelin depots are used for treatment of idiopathic precocious puberty. There are two reasons why when we add this. One, if the child has attained menarche before 9 years of age, that is one indication where you should be starting this. The second is in cases where we can have a difference in the predicted height can be changed. There is an advantage on the predicted height. It is there only if we start it early itself. In those children who have actually had a puberty and coming late, the height advantage will not be there. And the third, another common reason when we start puberty is the psychological maturity. The child is not, especially the female children in the third standard and all, they're not mature enough to deal with the puberty and they can have a general cleanliness and that how to adjust with. That's a psychological impact of puberty which leads children can become introvert, depressed or anxious, and also so that is also another indication for halting the puberty with leuprolide deposit.
Do we have any named criteria, specific criteria for selecting to whom to give medication?
Yes,
yeah, definitely.
The specific criteria is there. We follow that guidelines where to add. So very rarely also we go offline for the psychological reason alone too. In certain children, like those with precocious or like cerebral palsy children, even if the age is late, the height advantage is not there. We usually go for till it is manageable for the children. And usually use leuprolide depot once in 3 months. 11.25 milligram preparations are there. 3.75 milligram preparations are there. 3.75 milligram. It's according to the weight or according to the response. To 3.75 milligram, it is given deep IM. You can use monthly. If it is 11.25, you can go for 2 to 3 monthly intervals. In one injection, 2 to 3 monthly injection intervals.
And what is the endpoint, madam? What is the endpoint, madam? What is the endpoint? Endpoint? What is the endpoint?
Till the age of puberty is till the normal age of puberty is reached. Or till the
Sir,
bone,
sir.
the height age, there is no further height advantage because of this. Usually we continue for 11 years for females and 12 years for boys. That's the guideline criteria.
Okay.
And
How
there's
frequently are you using it now? How many children you have used it in your practice?
my practice are more than I think more than 100 or 150 children, sir.
In how many years?
I've been practicing for past 5 years, sir.
Okay.
Ramakutty sir was asking, sir.
No, I was just saying that, maybe this trend of children not being encouraged to run around or play is a big factor. I don't know. So I think as pediatricians, you should all advise parents that children should be given time to move around and play, and so everybody.
But sir, Padmanabhan sir has told an important point, sir, actually, because pediatricians are themselves, pressed to write nutritional supplements. Am I right, Soumya madam?
Yes, sir.
So nutritional supplements, we pediatricians are also, parents ask for writing nutritional supplements
Yes,
also.
sir.
So that is being significant in this study and all, actually.
One more point I want to say, that when we see that clinical aspect as a whole, we can see that children are becoming more, we are getting more of young onset diabetes, dyslipidemia, metabolic syndrome, very young onset type 2 diabetes and dyslipidemia we are facing. And we are also facing younger age of puberty. So all these can be seen as different phases of the same pandemic. So we as pediatricians are at that's the first point contact for prevention. I suppose.
Right.
Dr. Soumya, if you want to know, when I was a house surgeon in SAT hospital, when the first case of diabetic ketosis came, the assistant professor at the department did not know how to manage. She panicked. She made me run to Professor Matthew Roy here, there. And when I came out of the Alain Hospital in the Gulf, which is how we are going to, almost every month we had a diabetic ketosis. We had a protocol. The nurse there knew how to do it. She will never ask anything. How much insulin to give, how much IV to give, when to stop. Everybody knew. So become such a rampant thing, juvenile diabetes, but it has not become as rampant as in the Gulf. Gulf, it is horrible every month. Every month, 2-3 cases. And if any one of you, your colleagues or anybody wants to specialize, very good to be a diabetic specialist, juvenile. I'm sure because of this pump, everything, they have so many patients. Because they come with the pump to me, I don't know how to adjust it. The whole thing is a problem. The diabetes. Therefore, we call my assistant Varsha from home. She has become so busy there. Therefore, this is a horrible thing. I think it has gone with the hygiene theory also. It has got something to do with hygiene theory also. And we see more asthma also now. Wheezing. This has to do with the hygiene theory, probably with sedentary habits. Now, diabetes ketosis is such a common thing, but even here it is not as common as in the Gulf.
Thank you, sir. Now, if there is nothing else, actually, we can think of concluding the session. And I would like to thank Dr. Soumya madam for her excellent mentoring and the wonderful class, the enlightenment, and the wonderful presentation by the two postgraduates. Over to Dr. Srijit Kumar. Srijit, sir.
Anju, please conclude. I'm out of session. Yeah.
Okay. I think.
Anyway, Anju, the one good thing you showed me is we have a very good pediatric endocrinologist in Cosmo whom we can refer to. That I can.
Yes, sir. Actually, that is one important thing, sir. Actually, she should be, appreciated. Thus, actually, that is one of the reasons why we have roped her in for this session and all. She's having a good practice and all, and she's
practicing in Trivandrum. I didn't know Cosmo had a pediatric endocrinologist. Practicing in Trivandrum. Now
she's having a good.
There. I didn't know that there was a pediatric endocrinologist in Cosmo. Okay.
Okay, thank you, sir. So I think it is time for us to call a day. It was a great session. I think, Soumya madam, it was. How did you enjoy the session, madam?
Really enjoyed it, sir. Really enjoyed it. I hope my
Thank you,
point
madam.
got attended.
So yeah,
Yes.
it is almost time for. So I would like to thank Ramakutty sir for that. Today's sir was very vibrant and it was so energetic and it was so interesting, sir. Sir, thank you so much, sir, for your valuable time and class. And also Dr. Patnavan sir has been our coordinator of the journal club. And thank you for the coordination, the guidance, and the wonderful beginner sir was telling. And also Dr. Jisna Najeem, who wonderfully presented, and Dr. Fathima A. Rahim, who wonderfully analyzed. And I also thank Dr. Srijit Kumar sir, Secretary EAP, Dr. Benno, Dr. Ekha madam, and PM Sundar sir was also there, and Dr. Rosemary, and all those who were present. And till the next session, we will call today. Take care. Have a great time. Thank you.